Welcome back to Beyond the Prescription podcast. Today we have somebody that has traveled from another state to talk to us today. So we are interviewing Dr. Will Thompson. Hi.
Hi.
Thanks for coming.
Yeah, thanks for having me. I'm pretty excited about what we're going to talk about today.
Yeah, absolutely. We're here to spread community awareness and patient education, and you have taken time out of your busy schedule, and it speaks very highly of how much you care about people. So thank you for that. But we do need to make it known that you told me that you weren't going to come over here unless you saw a white squirrel.
Look, I may live across the state line, but I come over here. It's not that far away, and I've been here many times and never seen a white squirrel except for on the murals and the signs.
Okay, well,
So,
today
I don't know if they're
we
real.
made that happen.
We did. There's one right here.
Yes.
It's much closer than any of them I've ever seen because they've always been 2D. This one's 3D.
Yeah, and now
So,
you know they really exist.
They do.
Yeah,
Yeah.
that's good.
Yeah.
So, Dr. Will, give us a little bit of background about you, something interesting about you. Just
Sure.
tell us about you.
So I am from a little town outside of Vincennes, Indiana, and grew up hunting and fishing. Went to Indiana University for undergraduate. Went to West Virginia School of Osteopathic Medicine for medical school. Back to Deaconess in Evansville, Indiana for family medicine residency, and then since 2021, I moved back up and I practice full-time with my dad in family medicine in Monroe City, Indiana.
Oh, great.
So, yeah.
Okay. Well, you do quite a bit of different things.
Yeah.
Right?
I'm a jack of all trades,
Yeah.
master of none.
That's good. That's good. So you, Dr. Will and I, we met working in the emergency room together.
Yes.
And then we randomly ran into each other getting on a plane or a train.
On a train. To Chicago last year. Yes.
Last year.
Yeah.
And then I
Yeah.
hadn't seen you for a year.
Yeah, I kept working in the ER, but I didn't see you on my shift days, and
No.
it could have just been a matter of just being on the wrong hour of the shift. So,
Yeah.
But we crossed paths again, and you asked me if I could
Come on
join
over.
in on this podcast. So,
Awesome. So, Dr. Will, I sent you a text message, and I'm like, hey, we still on for the podcast?
Yeah.
And I get a response back. I'm planning on it. And what catches my eye is your profile pic.
Profile pic,
Icon, yeah.
Yeah.
So, what were you doing? It looked like you were in like a fighter jet.
Yeah. So that's also one of my passions outside of medicine is aviation.
Okay.
And I was with a friend in his experimental home-built plane, flying with him that day.
Whoa.
I fly. I own my own plane, a Cessna Cardinal, 177B model. If anyone knows about that on this podcast, they'll know exactly what I'm talking about. But I fly out of Lawrenceville Airport mainly. So yeah, been flying for a little while now.
And you love it?
Oh yeah,
Okay.
I like to go places and do things and go to airport restaurants. I'm sure if people know the old term is going for the $100 hamburger, because the hamburger usually costs $5 to $10, and the fuel to get there and back is about $100. So it's kind of gone up to like $150 now. But it's more for the experience than it is for anything else.
Right.
So yeah,
That's good.
So
Because whenever I saw that picture, I was like, he looks like you were on Top Gun.
oh yeah.
I mean, you got like the straps.
Yeah,
and
I had the shoulder straps and that plane of his
the
is
clouds in the back. I'm
yeah.
gonna get that picture.
Yeah,
So-
that plane is wild. It's got a glass canopy, just like a fighter jet.
Yeah.
And it's got a really large engine for a really small body plane. So it's kind of an aerobatic plane, is what it is. So you can do all sorts of things. And I told the person who owned it, I go, let's just keep it PG today. So he's like, well, let's just see how fast we can get to 10,000 feet. And I go, okay.
So is that what like sparked it in you? Like ever since that?
I was actually flying at that time, but
okay.
And that gentleman who owns that plane is the person who got me most interested in aviation, but as a young kid. But I didn't have enough time during medical school and residency to fly or learn how to fly. So I've learned since I got out of residency.
That's awesome.
But he owns 3 planes, and one of them is a 1942 Stearman, which is it's a bi-wing plane, and those planes were trainers for the U.S. Navy during World War II.
And it still flies?
It still flies, yep, and it is still going strong. I flew in it just the other day. So, yeah, it was not. I mean, anyone on this podcast may find this interesting, but those planes are built like super strong, indestructible. If you crash them, the wings would still be all there intact. But so the other day I was with the person who was flying it, and he's like, "You want to do a loop-de-loop?" And I go, "Yeah, that sounds like a great idea." And I go, and we're at like 3,000 feet, which isn't that high, but it's high enough. And I go, "How many feet do you drop when you do that?" Because you
have to drop to go.
Because you drop. And he goes, "I don't know. Well, we're going to find out." So, so we did just fine. I'm still here today. So.
Okay, that's good.
But yeah, he just gave her some fuel or gave her some throttle and pulled her back, and we just went, meow. In a 1942 plane, so bi-wing, yeah.
That sounds fun.
Yeah. So, but yeah, I've been flying with him as just a passenger for years. He was my neighbor growing up at home. So, but he got me interested in it, and so I finally had the time to do it, and I've been flying for a little over a year now. So,
love it.
Yeah.
Love it.
Yeah.
Let's dive in about what you specifically do in all of the different realms of healthcare. One thing that you told me that you do a lot of is colonoscopies and EGDs.
I do.
So, let's just start with whichever one you want. What is an EGD, or what is a colonoscopy?
So we'll just start from the top down. An EGD stands for an esophageal gastroduodenoscopy. It's a mouthful, or EGD for short. EGDs are commonly done for epigastric pain or atypical chest pain once a heart condition is ruled out. If you have difficulties with swallowing foods or water and that gets stuck, we can go down there and dilate the area with a water balloon, essentially is what it is, in order to reduce your risk of having a food bolus, which usually lands people in our ER, occasionally. So we can also rule out I just had a kid the other day that I diagnosed celiac disease in because he was losing weight, had difficulties with just maintain a steady weight, and just all around felt terrible. And we did some simple blood work, and it was concerning. So we did a follow-up EGD, and official rule was celiac disease. So, and that's a duodenal issue, celiac sprue.
That you go in and do a biopsy on?
Yeah.
Okay.
Yep. So, but EGD's common practice. You also will do an EGD if you're having anemia, if it's iron deficiency. A lot of times people will have what we call arterial venous malformations, which are just little areas in any part of the colon, honestly, but they can be as high as the stomach and duodenum, and they just slowly bleed and leak out blood. And
right.
So we can fix those as well.
Right.
So
I want to veer off just for a second on the anemia, since you mentioned it. With like, if you find somebody that is anemic, it's almost essential, right? If they don't have any other reason, that you're going in and looking.
Yeah. So I would just do, most people will come in and they'll either tell you, hey, I'm having dark stools, or blood in my stool, or they'll be like, I'm just more tired than usual. Stools really haven't changed. Bowel habits have not changed. So just simple blood work is where we start.
Yeah.
Usually you can find that it's usually iron deficiency anemia is the most common type of anemia. You can do a hemoccult blood stool test. But I'll be honest, sometimes those are not as helpful, even those, sometimes they're positive, which a hemoccult is just a stool sample that's just tested for blood. But AVMs can pop up, bleed for a little while, for a day or two, and then shrink back down and stop bleeding. And you may just catch the stool that doesn't catch the blood. Okay. So if you have someone that has a negative hemoccult and you watch them for a little bit longer and they continue to have slow decreasing hemoglobins, you may still want to do an EGD.
Okay.
So
That's great. That's great. Because I mean, we see that, we catch that a lot, in primary care, You're like, all right, why is your hemoglobin trending down?
Yeah, for no other reason.
Exactly.
Yeah.
Exactly.
So,
what is a colonoscopy?
So a colonoscopy is a scope, just like an EGD, but of the colon. It looks like the exact same scope as the EGD scope. It's just a little bit longer. And we can go all the way through the entire colon and a little bit into the small bowel and look directly into the colon and see any type of polyps or cancers, or like we talked about in the top area, there are sometimes you can get AVMs or those arterial venous malformations, and you can fix those as well.
You just like cauterize them, or what do you do?
Yeah, so we use this device called argon plasma coagulation, or APC.
Okay.
And whoever came up with that was a genius, but it's a non-contact way to coagulate something.
Okay.
Because AVMs, if you've ever seen one bleed, they really go. If you touch them, they will just start going.
Okay.
So this is a nice way to be able to just lay out and stick a catheter right next to it without touching it, and then you can hit the pedal, and it'll basically cast a shower of coagulation material on the surface, and it'll cauterize it.
That is awesome.
Yeah.
I actually didn't know that was a thing.
Yeah, it's really nice. We, back in the day before I was training, there was two types of ways, three types, but hot forceps, you could grab the tissue and burn it. You could use a heater probe, but you had to use a lot of pressure and you had to heat it up, so basically contact again. And then the last way is to inject it with epinephrine. Today we use hot forceps occasionally. We inject with epinephrine a lot of times if there's an active bleeder going on. We can inject, slow down the bleed, look for the vessel that's actually bleeding, and then clip it.
Okay.
So, but we use APC a lot on things that aren't bleeding, but we know that they have the potential, especially in someone who's got anemia.
Okay. You just totally taught me about that, because that is really interesting. So I guess for procedure wise and things like that, for EGDs and colonoscopies, everybody complains about the prep for the colonoscopy. Is there any prep for an EGD?
There is no prep for the EGD. You just eat your normal meal the night before and nothing to eat or drink after midnight. We usually tell most people to hold their morning medications. Unless it's done in the afternoon, then I don't care, but I don't want to see anything when I'm down there. They need to just hold their blood thinners like any other surgical procedure and hold any anti-inflammatories 5 days prior, but otherwise it's much easier than a colonoscopy. Just kind of show up.
Okay.
So,
do you? You might have mentioned it, but do you do the treatments like the banding for esophageal varices?
I personally don't.
Okay.
As a family medicine trained endoscopist, one of a couple things I don't do is variceal banding. And the other thing I don't do is ERCPs.
Oh, yeah.
So that's where the line kind of gets drawn between gastroenterologist and then what family medicine can do in training.
Okay.
So, but I mean, even in a local rural area, our gastroenterologists don't do a lot of ERCPs. They do variceal banding. So if I were to see something that really needed to be addressed, I could get it to a colleague and let them address it.
Yeah.
But, most times I even manage a lot of my patients that come in for their own bleeding of some nature instead of sending them to gastroenterology, and I just do it myself.
Yeah.
So.
Very good. And I'm sure they appreciate that too.
Yeah.
So what is something like, what is a specific diagnosis that you're giving your number one diagnosis that you give patients on a daily?
Screening for colon cancer, and then history of polyps that need surveillance colonoscopies.
Okay.
Are you talking about for colons, or are you just talking about primary care?
No, colons.
Okay.
Yeah.
Yeah.
That would be that for the screening. So you're just doing the majority of the screenings and checking the polyps.
Yep. Removing any polyps that we see along the way. We also get change in bowel habits. So if someone who has had normal stools, what they consider normal, I have to clarify what that actually means to them.
Yeah.
But someone who starts getting profuse watery diarrhea that's not determined to be infectious, or abdominal pain, we'll do diagnostic colonoscopies for that as well. And it's really not any different of a procedure. It's just a different look in the colon, what you're trying to evaluate for. So for diarrhea or abdominal pain, a lot of times we'll do just random biopsies on the way out. If it's in a middle-aged adult, I'd say 40s on up, we're looking to rule out microscopic colitis. It's more common in the 5th and 6th decade of life, but it can be as young as the 40s. And microscopic colitis is it's a form of inflammatory bowel disease, but it's not like the common one that everyone knows about, which is Crohn's and ulcerative colitis. So it causes more of a watery diarrhea, abdominal discomfort, and it's treated without being really invasive like the ulcerative and Crohn's disease patients.
So are you seeing a lot of that?
I see it more in my probably 60s and 70s year old patient than anyone else.
Okay.
And it's pretty easy to treat. It's just a oral steroid that they swallow, a non-systemically absorbed oral steroid. So budesonide comes in an oral form that's not systemically absorbed, so it doesn't affect your people with diabetes or weak bones or other things. It just stays right in the colon.
I did not know that.
Yeah.
So
Intercort is the brand name.
That's amazing.
Yeah.
So you just put them on that. How long do they take it for?
It can vary, but sometimes several weeks. Sometimes shorter, and then they'll need a follow-up colonoscopy to see if the disease has calmed down, and most times it has.
That's really good, because that is something I just remember in primary care. We're going to throw some prednisone at you, and you're going to end up...
And trust me, I throw several of my colitis patients with prednisone, and I am reminded later by them how much they didn't appreciate that.
With their blood sugars.
Yes, with their blood sugars, and their significant other reminding me of how excited and nice they were at home.
Rage. And up all night.
Up all night, and they ate a lot, and now they're swelling, and their mood changed. So,
and then you're reminded. That's funny. So what is, on the colonoscopies, so you talked about the polyps, whenever you go in and you see polyps, you're going to try to remove them all, or is there just certain ones that need removed? Is there a certain family medical history? What? Yeah,
so let's just start maybe where we start first, just screening for colon cancer. Is in 2019, we changed the guidelines from 50 to 45 for all patients. And 10 years prior to that, if you have a family history of colon cancer.
Okay.
That's not changed, but the 45 did. If we see a polyp in there, depending on its size and how many you have, determines your interval surveillance follow-up colonoscopies. And if we see a polyp, we remove a polyp. There are sometimes you'll have patients that have a diagnosis of a hyperplastic polyp. There's 3 main kinds of polyps. There's adenomatous polyps, which accounts for the majority of colon cancers.
Okay.
There's sessile serrated polyps, which accounts for the second largest majority of colon cancers. And then there's hyperplastic polyps, which are benign, very rarely turn into colon cancer.
Okay.
We consider them not precancerous at all. And they can be numerous in the rectum. They're more common in the rectum.
Okay.
So, and I always tell patients, I go, hey, sometimes I see them and I don't remove them in the rectum. It's no different than me doing a skin exam on them in the office. Am I going to remove every single nevi or mole on their arms? No, because I've got enough knowledge to say that this doesn't look like it's going to be a problem.
Right.
Versus maybe some other looking funky structure. I hate to say funky, but
yeah, you know whenever you see
I
it.
know when I see it that even if it's on your skin or if it's in your colon, I know that I got to remove that because it's really concerning to me.
Yeah, very good. And then you're just going to monitor.
And then
whatever.
I monitor. Yeah. So, and then family history plays a role. If they have several first-degree relatives, so you only need one first-degree relative to decrease your screening interval.
So whenever you say first-degree relative, explain that.
Mom or dad, brother or sister.
Okay.
So direct blood lineage. Not your spouse, not your stepbrother, not your boyfriend. I've gotten some of those questions before. So
Not your neighbor.
Not your neighbor. Not your church friend. First degree, mom, father, mother, father, brother, sister.
Okay.
So if one of those have a colon cancer in their lifetime, you'll need a colonoscopy at the
age that they were 10 years earlier.
10 years prior. Yep. And then every 5 years after.
Okay.
So
still talking about polyps, I guess on the colonoscopy with the polyps, in primary care, I was almost 75% able to get somebody to do a Cologuard versus a colonoscopy.
Yeah.
Sometimes before I ask this question, a Cologuard, a home like DNA test for what's your thoughts on those?
I am skeptical at best.
Okay.
As a family physician, I need to be transparent with my patients, so I always offer Cologuard as an option.
Yeah.
I don't recommend them, though.
Right.
And this is my standard speech. I'll say, hey, looks like you're due for a screening for colon cancer. There are two methods. There's a Cologuard, which is 92% effective at finding cancer. It's 42% effective at finding precancer. There's a colonoscopy, which takes a direct approach inside the colon. It does require a day off of work and a night of prep the day before, but it allows us to directly see inside the colon and remove anything that we find along the way. And unfortunately, I've just had enough failures of Cologuards in my short 3 years post-residency that I do not think that it's worthwhile.
Yeah. So whenever you say failures, just because I don't have a large amount of these stories, but I do have some stories from my primary care of the colonoscopy the Cologuard would come back negative.
Yeah.
But then very shortly down the road, we would find a colon cancer.
Yeah.
Or something similar along the lines of that.
Yeah, or a big polyp. The 8% of the people that don't get screened positive for colon cancer on that test, that's still a low number. I will put out that Cologuard has now come out with a Cologuard Plus box now, which is 95% effective and 45% for precancers, I believe are the numbers.
Nice.
So it's a little bit better. It's still not
as visual.
It's not as good as a colonoscopy, but
yeah. So if you have a patient that, is just very resistant to a colonoscopy, you're definitely going to be going ahead and pursuing ordering them a Cologuard and getting that test done.
Yeah, I will work really hard to encourage them that the gold standard of care is a colonoscopy.
Yeah.
Just because, and I explained to them, I go, I've had several patients that, for example, I had a gentleman last summer had a Cologuard. It was negative. His father was diagnosed with colon cancer last fall. Mm-hmm. And I said, hey, we really need to get a colonoscopy now that your father's been diagnosed. And he did a colonoscopy with me this spring, and I found a 15 millimeter polyp, which in the grand scheme of polyps, anything over 10 millimeters is considered an advanced polyp.
Okay.
Cologuard found it to be negative. That's a failure in my mind.
I see.
Okay.
Yeah.
I had a lady right when I first came back. She had been having some epigastric pain. We ruled out that it wasn't her heart. I did an EGD, found a bunch of polyps in her stomach. And if you find 20 or more polyps in the stomach, which most polyps in the stomach are not like colon polyps, they're almost always benign, but it increases your risk for colon polyps if you have 20 or more in the stomach. Did a colonoscopy on her, and I found 13 precancerous polyps, native Cologuard. I had another gentleman, one more example of a negative Cologuard. This was 2 summers ago, and he had gone to the ER with abdominal pain. He had gotten a CAT scan, and they saw something in the sigmoid colon, but were not quite sure what it was. And I ended up finding about a 20 millimeter polyp in the sigmoid colon, negative Cologuard just within 6 months. I mean, polyps take a really long time to become cancerous. On average, about 10 to 15 years before a polyp turns into cancer. Okay? That polyp was there 6 months prior.
Right.
Okay? And for a test that proves nothing as far as a safety net for patients, I don't want my patients to have a false sense of security. Okay?
Yeah, that's good. That's a good... Yeah.
So, and then the final thing that I'll tell my patients, and I go, hey, if you get a positive Cologuard, and I go in there and I find a big polyp, you're probably going to get the same number of colonoscopies that you should have gotten prior had you just done them prior. Because now, usually, if I don't find a cancer, I find a big polyp, and I'll have to remove it in stages. And that basically means is I'll remove everything that I can. They'll have to get a follow-up colonoscopy in 6 months, most times, and then 1 year after that. So they'll get 3 colonoscopies within an 18-month period versus just doing one every 5 to 10 years.
Right.
Just get a colonoscopy. Just be done with it. And know that your chances of having a good outcome are much greater than putting your chances into a box by a company who's just trying to make a profit off of the people of America.
Yeah.
So.
Yeah. I do want to ask you on the polyp situation. Yep. So if you have someone get a polyp removed at some form in their life or some time in their life, certainly, and they go and do a Cologuard later, is there something that's going to show up on that might not be? So
if you read the fine print in the Cologuard, it will say if you have a family history of colon cancer or a personal history of adenomatous polyps, you are not a candidate for Cologuard.
Yeah.
And that's been something that has gone on for quite a while. And I will say, even in my own office, I feel like marketing of the product has superseded the correct way to do medicine sometimes by the reps for products.
Yep.
And I really enjoy talking to drug reps and product reps, but I feel like that little tiny tidbit of fine print information wasn't probably made clear to your primary care physicians and nurse practitioners of the world.
It wasn't. I can tell you that for sure.
And so people end up getting a Cologuard later for screening, come out negative, but they do have a personal history of adenomatous polyps, and they weren't ever a candidate by Cologuard's
standards. Yeah. That is kind of something that, like, I remember with a few patients that I had to, like, learn the hard way on, I was given this amazing way to help people get colon cancer screenings, but I wasn't given that information.
Yeah, here's
You
the
hit that.
superficial stuff,
Yeah.
but there's some fine print that no one really talks about.
Yeah.
And that's a good just tidbit of information for someone that's just coming out of, a residency or nurse practitioner or PA school. I like talking to drug reps because they bring me kind of new products. They open my eyes to new medicine or new materials.
Right.
And but doesn't mean two things. It doesn't mean I have to use theirs product. And second is it means that you also have to do your own digging
And your research.
on it.
Yeah.
Okay. And they will usually bring with them like the New England Journal of Medicine article that tells everyone why their product is the best product,
Right.
which is great. It's a good starting point. And then I go on further and look for JAMA articles or more New England Journal of Medicine articles.
On that. Yeah.
That weren't supplied by the big pharma itself.
Yeah. Big pharma for sure on that. And one thing that I do value the drug reps for is they will often help me know how to get a medicine approved.
Yeah.
They know that stuff sometimes like the back of their hands. Not all of them, but some of them are like, this is all you have to do. And the patient will have to pay, whatever, $25. So that's always a good thing.
Yep.
Are you seeing an increased rate in colon cancers?
Actually, we're seeing an increased rate in our younger patients, and younger for colon cancer is our 40s and 50-year-olds.
Okay.
We used to see more colon cancers in our 60s and 70-year-olds, but and this is why the societies, associations, governing bodies of colon cancer got together and said we really need to reduce the age from 50 to 45, trying to prevent more of those upper 40s and lower 50-year-olds with advanced stage colon cancer.
So why? Why? What's your opinion? Why are you seeing that?
I mean, this is just because I'm in primary care. Obesity, I think, plays a large role. Processed foods, increase in red meats. And one of our big things for a common topic for a lot of patients are they say, well, I got diverticulitis. I'm like, you probably have diverticulosis and you've had a flare in the past. And they're like, yeah, my doctor used to say that seeds and peels and nuts and I gotta cut all that out. I'm like, we used to think that was the issue. We've got more information now, and we think that it's not that necessarily causing the issue. It's our inflammatory products that we eat, so red meats and processed foods that increase the rate of inflammation in the colon. And the reason why ulcerative colitis and Crohn's disease or inflammatory bowel disease are so specific on screening for colon cancer no more than every 2 years before you have another colonoscopy in ulcerative colitis and Crohn's disease, sometimes more often than that.
Okay.
But the reason why is inflammation in the colon increases risk for cancer.
Yes.
Okay.
Yeah.
So products that increase inflammation in the colon also increase your risk for cancer.
Yeah.
So our red meats. So I basically tell my patients if you've had repeat flares of diverticulitis,
what does your diet look like?
What's your diet look like, basically? I want you to increase fiber in your foods and reduce. I'm not telling anyone to like cut out red meats. I'm just saying we need to reduce. And
then processed foods, like you're talking about the boxed foods, bagged foods, all that
your
stuff.
deli meats, your processed meats. Yeah. So
is that because of like the preservatives in them causing the inflammation in the bowel and the stomach and everything?
Probably most commonly it's just ongoing, not necessarily a fresh look at whatever food it is.
Yeah.
So
Yeah.
yeah.
That's good.
But in our society, we've grown accustomed to a faster food diet. Not saying that
modern American diet.
Not saying that fast foods is the chain, but a faster food is the diet. So, I have a lot of road truckers in my practice, and they see me, but when they're back home, and I'm like, the person you think of a road trucker is the gentleman or a female who a little overweight. They get their big swig, and they stop at their trucker stops and they get whatever sandwich meat, fried or something. And I always tell them, I go, hey, I'm not opposed to you eating some of those occasionally, but sometimes those people have a fridge on board, or they can pack a lunch.
Yeah.
If you can pack something that's maybe a little bit more fresh, or I personally like blueberries, and some other sorts of vegetables. If you can offset some of that, I'm not saying remove all of it because that's a culture shock.
Yeah.
But alter some of your diet, that may help with other things as well.
Yeah, so, and like slowly make those changes.
Yeah. I just was talking to a patient yesterday and in the office, and I go, hey, he goes, I think I need to start working out more. And I'm like, you know what? I don't disagree. But I also don't need you watching the advertisement on TV that says, tomorrow you're going to do 50 push-ups and the next day you're going to do 100 pull-ups. And I'm like, just why don't you do, 10 sit-ups and then, and take a walk around the block. Yeah. I don't need you running. Just go walk. I just need you to be active.
Yeah.
And active for a lot of people is like, I got to go to the gym. And my definition of active is, can you just walk around the block? Can you walk around the yard? Now, if they're have a gait instability, the yard's not a great place for them. But the sidewalk is okay. Can they walk down to the mailbox if they don't have a sidewalk? They live out in the country. Can you walk to the mailbox a couple times? I just need them to move.
Right. So, and start with 5-10 minutes a day.
Yeah.
And then just start adding.
I don't need it to be all in one day, because then the people get, in a sense, burn out over a short stint.
Yeah.
So, just move.
Yeah, absolutely. So, you do all of the EGDs, colonoscopies. How many days a week are you doing? Those procedures?
Wednesday mornings and all day on one Monday of the month.
Okay. And then you're doing like some family medicine, and then you also do some sports medicine. Is that right?
Yep. On Monday mornings and Friday mornings, I do sports medicine clinic for Good Samaritan Hospital.
Okay.
And I'm the team physician for Vincennes University, and we provide the athletic training for Vincennes Lincoln as well. There may be another school in there, but I believe it's just Vincennes Lincoln. And so I take their sports-related injuries from that in addition to anything else that comes in. And sports medicine is a colloquial term for just saying I do industrial medicine, so workman's comp injuries from coal mining industrial work to sports medicine is, you think of an adolescent or a teenager that has an injury.
Yeah.
So... and that's actually a subspecialty of family medicine. If you wanted to go into it and just do that as your day job, you can. I decided not to do that because I felt like I had enough training in family medicine to do the sports medicine work. So, but you can go on and do a subspecialty fellowship if you desire.
Do you enjoy doing that?
Yeah. I mean, family medicine for me is it breaks up the monotony because I go from a high blood pressure patient to a diabetic to a newborn exam to back to a COPD to heart failure to cancer, hospice, back to another newborn all day long. So it really helps create an opportunity to see so many different things. And family medicine is as I kind of mentioned jokingly earlier, it's a jack of all trades, master of none. Yeah. So, and then I get to do procedures associated with it. So not only colonoscopies and EGDs, but I do my joint injections. I do trigger point injections. I'm an osteopathic physician, so I do osteopathic manipulative therapy.
So you're going to crack my neck?
Yeah, we do manipulation of the spine, anything that hurts as far as extremity goes. And then we also do abdominal manipulation as well as cranial manipulation for headaches and other things.
Oh, okay.
So, yeah.
Very good.
And
so
then
you really are a jack of all trades.
Yeah. And then skin lesions. So we do our skin cancer checks and cryo or biopsy or excisions. And then we're kind of in the middle of nowhere. Munro City, if anyone looks it up, is about a town of 500 people.
Oh.
So a lot of people use us as, now it's just our patients, but we become their urgent care, their ER. Sometimes I wish they would have just gone to the ER, but they're like, no, we're going to see Dr. Thompson.
Yeah.
We just had a gentleman the other day who came in with a nail in his foot. He was a farmer, got a nail through the shoe. He walked a quarter mile through the field with a nail impaling his foot through the shoe. And instead of going anywhere else, he just said, oh, I'm going to go there. So, and I was able to, numb up his foot and then remove the nail.
Good.
And
get him a tetanus?
Get him a tetanus and some other goodies. And saw him a lot for a few days, and he did just fine.
Good.
So, rural medicine is, for me, I wouldn't want to practice in suburban or urban medicine. That's just not my thing, because I get to do basically all facets of family medicine.
Yeah.
The only thing that I'm not doing is delivering babies. I did a lot of that in residency. I actually really wanted to do it when I got home, but it didn't really work out because of the office location compared to where the local hospital was.
Oh, yeah.
So it's
that
about
makes
a 20-minute drive.
Yeah.
So
what led you to the emergency room?
Oh, yeah. So in residency, we had an opportunity to work in the urgent cares for moonlighting hours.
Okay.
And then I took a lot of extra shifts in our ER in Evansville.
Okay.
And then a lot of my friends, it became like 5 o'clock. They were going home. They were back in their garden. They were fishing. They were doing whatever. And I was like calling up my trauma surgeon friends, and I was like, "Hey, you working tonight? I want to hang out with you."
That's awesome.
And so I would spend extra hours in the evenings, whether it's urgent care, in the ER, or with my trauma surgeons, just doing cases as much as I could, because I knew I was coming back to middle of nowhere. I wanted to be able to take on anything that came into my office or ER and know that I had the confidence to back up what I could provide to them, and then know my limits at the same time. Like, hey, this looks like it really should go to my colleague, or my colleague that's down the next city over, which most of our things go to Evansville for trauma stuff. So
right, unless I feel like if it's we send it up to Indy,
Louisville, Vanderbilt, something like that. But a lot of our car wrecks and other things will end up going to Evansville. So if we can't manage it here,
So what is something, just to kind of wrap up, to give a piece of your passion of what you feel with healthcare and people's health? What is something that you would like to leave for our listeners?
There is so many things available for as far as information goes these days, and I want patients to be as available to the information that they can. And if they do their own research, I actually encourage it. And it provides a lot of discussion opportunity in a room. I will leave you on one thing to go along with that discussion. 50% of people in America will die of a cardiovascular-related event. That could be a heart attack, a stroke, peripheral arterial disease, something along that line. To get to that point, will have needed many years of several factors. And a few of them are high blood pressure and cholesterol. And then the third one that none of us can change are our genetics.
Right.
Okay. And one thing that hit home more than anything, and my dad does as well, he actually got me on it more than anyone, is that managing your cholesterol really is important for family medicine. As we know that 50% of people will have some sort of poor outcome related to a cholesterol-related event. And now, fortunately, there have been a lot of changes in cholesterol management. We are really lucky, to be honest. And in the next 5 years, we're going to be even more lucky, because there's some really cool things coming out in the cholesterol game.
Nice.
For the longest time, we've only had statins. And statins have gotten a bad rap for a few reasons. We don't have to dive into all of them right now, but they've gotten a bad rap.
Yeah.
And there's newer medications out there that are non-statins that are still oral. There's injectables now. There's two types of injectables. There's the Repatha and Proluent. And then there's the Leqvio. And both different types are really good about lowering your cholesterol. And then there's an actual newer class of things coming out looking into ApoB and lipoprotein little a. We actually call it the little a because there's a big A out there. Lipoprotein little a as being indicators for high risk for cardiovascular disease. And there's not a treatment right now for correcting lipoprotein little a, but we believe that there will be in the next, we think, 1 to 2 years by the way the research is going.
Okay.
And it's gene technology, actually, for lipoprotein little a. And it's so fascinating. I don't know if anyone understands what CRISPR technology is, if we've heard of CRISPR.
I haven't.
CRISPR technology is able to actually replace a gene in your DNA and turns off the ability for the body to make bad cholesterol. Wow. And so your cholesterol, without any more medications, will just go essentially down to zero. Okay. And therefore no longer need a medication. And CRISPR technology has really come along a long way, and we think that it'll actually be mainstream here in the next couple of years.
Okay.
So
that would be like given like by an injection, infusion. Don't really know yet. But for our high risk, as with all things, when they first come out, it'll be our high risk patients first, and then it'll kind of trickle down to the more general population. Yeah. So, but cardiovascular disease, just strokes, heart attacks. And people are, unfortunately, the ones that come in my office, there are more concerned with strokes than they are with heart attacks because they see their neighbor walking down the street now with a cane because yesterday they didn't have a cane, but now they have a cane and their one arm is tucked up like this. Yeah. They see their other friend in church that now has a peg tube because they can't swallow food anymore. Yeah. They see someone in the grocery store that has this really large drooling area because they now drool because they can't close their mouth. Right. They don't really see the heart attack aftermath. Right. So they're more, their perception is just more concerned with strokes. So yeah, and that is very true. I mean, and even like the people you'll see have a massive stroke and then they're in the nursing home, for the rest of their life. So yeah, you are right on that. And where the heart attack is more of you're going to be on meds, you're going to be getting monitoring, and then you might not have much physical activity as much as you used to. And heart attacks usually don't kill people. We've come a long way with that too. We've been able to stop them early and treat them, and they don't have a lot of side effects. Yeah, but stroke people can tend to have a side effect that lasts long term. That lowers their immune system, increases their risk for infection and later death. Yeah. So, yeah. Good. Man, we could go on for hours on many topics. I have a lot of passionate topics, but that's awesome. Yeah. So thank you so much for joining in today at Beyond the Prescription podcast, where we interviewed Dr. Will Thompson, and we got to pick his brain about EGDs, colonoscopies, about general screenings for all of that. Also, all the other fun things that he does. And what he's passionate about, he has many passions, but keeping your heart health, right? Yeah. Keeping cholesterol down, keeping blood pressure down, things like that. So he is a family medicine doc that does some other screenings. So we just really appreciate him taking time out of his day and getting here to educate you, the community, and also other practitioners of what's available and what we need to be doing to make sure that we can be the healthiest and that we can thrive. Thanks for joining in.